Thanks, Aiman. This is an interesting topic. It's one that we face every day in the neonatal unit, isn't it? BPD is endemic amongst our patients, so we're going to take an evidence-based approach to see what works. Just some background. What is BPD? Well, it's the chronic lung disease of prematurity, as we all know. It's common. It affects at least 35% of babies less than 28 weeks gestation. And what we call BPD has evolved over the decades of modern neonatology. In the early days, and perhaps right up into the 80s, we had this syndrome, which we now call old BPD, initially described by Northway in 1967, which arose on a background of RDS with high pressure ventilation and oxygen toxicity. And the pathology seen there was cystic emphysema and fibrosis of the lungs. In 1999, Alan Jobe described what he called the new BPD, a term that's stuck. And this is in the era of antenatal steroids, and surfactant and gentle ventilation, but we were still seeing a problem. And he described it as a problem of arrested alveolarization and pulmonary vasculature development. And when we think about the pathogenesis, we shouldn't be at all surprised that our babies have problems with their lungs. Our babies at 24 to 28 weeks are in the canalicular or early saccular phases of lung development. They're a long way off having mature airways and alveoli. And so at this very vulnerable stage of development, we take them from the uterus and expose them to high concentrations of oxygen. We have trouble providing good nutrition. We expose them to inflammation and sepsis and cardiovascular instability, particularly patent ductus arteriosus. So it should be no surprise to us that these babies' lungs do not develop properly. BPD is a disease of long-term consequences to respiratory health. These babies spend more time in hospital during infancy. They have higher rates of wheezing and asthma in childhood and perhaps into adulthood. They have measurable changes to their lung function, airflow limitation and decreased exercise capacity. And not only do they have lung problems, they also have brain problems, problems with neurodevelopment, an increased risk of cerebral palsy, cognitive deficits, and behavioural problems. So BPD is a problem for us in the nursery and a problem for paediatricians, families and children throughout life. And it's a problem that's not going away. Here's some US data that shows that mortality over the years 2005 to 2014 fell steadily. Chronic lung disease really stays fairly stable, particularly over the last 5 or 10 years, up to 2014. Here's some data from Australia, which is even more alarming. If we look at babies between 26 and 28 weeks, we've seen their rate of chronic lung disease increase steadily, small amounts year on year, to the point where 2 years ago, we're well over 40% of babies with established BPD in that gestational age stratum. So we've got a big problem. We'd like to find some evidence-based solutions to that problem. We'll start with the easy one, surfactant we've already mentioned today. Natural and synthetic surfactant, whether you give it prophylactically or give it early, all of these surfactants reduce death or BPD, that combined outcome. It turns out that they don't reduce the isolated risk of BPD, but certainly reduce the combined outcome of death or BPD. And just a quick recap if anybody joined late. Minimally invasive surfactant therapy is one of the treatments that really does reduce BPD. Remind you that was a risk difference. If you expose the baby to minimally invasive surfactant, you reduce their risk by 8%, treat 12 babies to prevent 1 case of BPD. Moving along to caffeine, and these data come from the Caffeine for Apnea of Prematurity, or the CAP trial, led by Barbara Schmidt. And we know a few things about caffeine. We know that it's good for getting babies off respiratory support, whether that's intubation, any positive pressure, or supplemental oxygen. babies exposed to caffeine come off these therapies about a week before placebo-exposed babies. Highly significant results, clinically important results. But we're talking about BPD, and caffeine is one of the most effective treatments for BPD, reduces the risk from 47% to 36%, highly statistically significant. So there's a mechanism of action here, isn't there? If we get babies off the ventilator, away from volume trauma, they're less likely to have BPD. Some added benefits of caffeine: reduces rates of PDA and PDA ligation. But of course, the reason for doing the CAP trial was because we were concerned with the effect of caffeine on the developing brain. There was some animal work that suggested it might be harmful. So we were quite reassured at the end of the caffeine trial when we found that caffeine actually improved rates of death or disability, reduced in the placebo group from 46% to the caffeine group 40%. Again, a highly statistically significant result. So caffeine, a great way of reducing BPD. Treat 9 babies to prevent 1 case. Has added benefits, economic, and for the babies, it gets babies off supplemental oxygen and off the ventilator sooner, and it does so safely from a neurodevelopmental point of view. So whenever we find an effective treatment, we're always tempted to use a little bit more of it. So I think it's important we go down this little byway and ask the question, is more caffeine better? And there have been a couple of systematic reviews that have looked at this question in recent years. Some of our colleagues in Sweden and in the Netherlands wrote systematic reviews close to one another. Just draw your attention to some of the common themes that emerged. The first one is that the quality of evidence that they found was low to very low in both systematic reviews. So both sets of authors suggested that these were small trials, small numbers of trials. Even when we put them all together, we had insufficient infants to answer the question about safety of higher doses of caffeine. They said the quality of the included studies was low to very low, but there was a hint that higher dose caffeine reduces BPD and extubation failure. And these authors both independently called for a large randomised trial to determine the optimum dose of caffeine. I did a review of this topic if anybody's interested in more of our thoughts about caffeine. This was published last year, and included in that were some observations that I think are particularly pertinent. 3 years ago, it was observed that the rate of prophylactic caffeine use on the first day of life, being perfectly stable for about 10 years, trebled within the 6 years after the CAP trial was published, to the point where 2/3 of babies were getting caffeine on day 1 of life. Again, my hero, Alan Jobe, has got a nice word for this. He calls it treatment creep, and pertinent to caffeine, he cautions clinicians that particularly in high-risk populations like our very low birth weight babies, we should be using these drugs only for sound indications. And so for clinicians, I think caffeine is one of our most widely evaluated drugs. Its safety and efficacy have been well established for a specific dosing regime and applied over a duration considered appropriate at that time. And that was starting on around day 3 and finishing at around 34 weeks corrected gestation. If you've got a baby with a problem, a baby with apnea or a baby about to be extubated, caffeine is terrific. It's indicated. You can prescribe caffeine with confidence. But there is little high-quality evidence that caffeine is a safe and effective brain drug or lung drug, and its use in asymptomatic infants not requiring respiratory support does not appear to be warranted. The doors are open for researchers. It is plausible that caffeine prescribed earlier and continued longer than that used in the CAP trial, it might be better for our babies. But, and this builds on Junaid's experience with nitric oxide, something can look biologically plausible. You can have great evidence in animals, but you take it to a human and you might find the opposite. And we've got some examples here. Delivery room oxygen clearly too much delivery room oxygen is harmful. Postnatal dexamethasone, using it too early and in too high doses, is likely to be detrimental. Hypothermia therapy for hypoxic ischemic encephalopathy is great. It's wonderfully effective, but prolonged or deeper cooling for these babies is harmful. So this demonstrates what appears to be logical extensions of a proven therapy may mislead us into fruitless byways or disasters. So I would suggest that adequately powered randomised trials, at least the size of the CAP trial, 2,000 babies, with follow-up into infancy and beyond, are required to test these hypotheses and determine the safety of higher dose, longer duration of caffeine. Next, I'd like to talk about volume-targeted ventilation. And again, there's a physiological underpinning for this, the hypothesis that volume-targeted ventilation might be better than pressure-limited ventilation. And that relates to the theory of volutrauma, or over-distension of the lung, rather than pressure being the cause of preterm lung injury. And there's a strong theoretical reason to think that stable tidal volumes might reduce lung damage and also stabilise carbon dioxide levels in the blood and have a beneficial effect on the brain. So we undertook a review for the Cochrane Library. This was published 4 years ago, hasn't been added to. And just to look at the quality of the evidence, and we should always look at the quality when we look at a meta-analysis, and you can see that although we've got 20 randomised trials, the number of babies is quite small. We've only got around about 1,000 babies in these 20 trials, so they're quite small. The other thing to notice is this red area, and this refers to the unblinding of these trials. Very difficult to blind trials of ventilation, maybe impossible. Otherwise, the trials are of reasonable quality. But interestingly enough, the bottom line with respect to BPD is that volume-targeted ventilation successfully reduces the risk of BPD. The relative risk here is over to the left of the line of no effect. It's a statistically significant result. It results in an 11% absolute reduction in the risk of BPD. It's a highly homogeneous result, it's a very consistent result across all of the trials, in spite of them using different settings and even different ventilators between the two groups. This volume-targeted ventilation has a number needed to treat of just 9 babies to prevent 1 case of BPD. Similar findings if you use the combined outcome of death or BPD, treat 8 babies to prevent a case of death or BPD. So it's a treatment worth using. So I should say there is no difference in mortality alone, but some important benefits in other interesting neonatal outcomes, like pneumothorax, a halving of rate of pneumothorax, about a halving of the rate of severe IVH, and a similar reduction when you combine periventricular leukomalacia and grade 3/4 IVH. So, in conclusion, volume-targeted modes had reduced rates of death or BPD, reduced pneumothoraces, hypocarbia, severe cranial ultrasound pathology, and duration of ventilation compared with infants ventilated using pressure-limited modes. We need follow-up studies for these trials to test what it does to neurodevelopmental outcomes and to compare and refine the strategies that we might use when we volume target babies. Not time to go into details of how to apply volume targeting in a specific sense, if you're interested in this topic, we published an article 10 years ago giving some tips and tricks as to how it can make volume targeting work in the real world. Next, I'd like to move to postnatal steroids, and to cut to the punchline, the risk-benefit ratio of postnatal steroids varies with the timing, the baseline risk of the babies, and the route of administration of the steroids. Cochrane Library divides this topic into 2, early steroids and late steroids. So starting with steroids begun in the first week of life, Lots of studies and more than 4,000 babies, and the evidence is, on the whole, high for the major outcomes. The results, no difference in mortality. Early steroids do have some benefits. They increase the rates of early extubation. They actually reduce BPD and patent ductus arteriosus. But they come at a cost, and quite a severe cost. They have increased risk of gastrointestinal bleeding, risk of intestinal perforation, hyperglycemia, hypertension, and growth failure. But most importantly, there is evidence of early steroid therapy leading to long-term neurological harm, particularly increased risk of cerebral palsy. The authors of the review noted that the harm was associated with dexamethasone and not hydrocortisone, but the numbers of trials with hydrocortisone were quite small. So their conclusions were that the benefits of early steroids may not outweigh the risk. More long-term data were required, and particularly more trials of hydrocortisone are worthwhile, powered for long-term outcomes. And in response to this, the Premiloc study was conducted in France, low-dose hydrocortisone in extremely preterm babies. It's a reasonable size study, about 500 babies, and showed a reduction in, an improvement in survival without BPD from 51% in the placebo group to 60% in the hydrocortisone group. That's a p-value of 0.04. No difference in rates of the components of that primary outcome. No improvement in neurodevelopment at 2 years. And Michelle Schaffer and colleagues have performed an individual patient data meta-analysis on all of the trials of this question and found some promising results, but some problems with the trial. There was high rates of open label corticosteroid use in this trial, so the non-randomized use of steroids, which muddies the waters considerably. But they did find that early low-dose hydrocortisone increased survival without BPD at 36 weeks from 46 to 53%, decreased death before discharge, decreased PDA treatment, but no difference in some of the important respiratory parameters. The downside, and there always does seem to be a downside, is this common theme of increased spontaneous GI perforation and, in this case, an increased late onset sepsis, and no evidence of a benefit in terms of long-term neurodevelopment. So for us, around the world, people have reacted differently to these trials. We're not using low-dose hydrocortisone. We were concerned about the modest and imprecise treatment effect from the trial and some lingering concerns about exposing all extremely preterm babies to early systemic steroids. So this is a topic where we watch this space. More information needs to emerge before I think we can use this treatment with confidence. If we move to the late steroid trials, fewer numbers of trials and fewer numbers of babies, but still well over 1,000 babies. And again, the overall quality of the evidence is high for the major outcomes. So with respect to the outcome of death to latest follow-up, no significant difference in rates between the steroid and the control group. The steroids do decrease risk of BPD, take the relative risk down to 0.77. And the combined outcome also reduced in the steroid group, death or BPD. Again, there's the downside of steroids: hyperglycemia, hypertension, and gastrointestinal bleeding. Long-term rates of death or major disability, no difference between the steroid and control groups. And the conclusions of these authors were, I think, appropriately cautious. Benefits of late steroids might not outweigh the risks. May reduce mortality without increasing long-term neurodevelopmental risks, but the quality of those long-term studies was limited. The authors of this review suggested we keep late steroids in reserve for babies who were unable to wean from the ventilator. And if we're going to use steroids, then we use the lowest dose for the shortest duration that we can get away with. Looking at why some trials of postnatal steroids are giving mixed results and posing something of a riddle. Jack Sinclair, sadly no longer with us, but a very original mind in neonatology, had a great idea of solving this riddle. And his hypothesis was that the baseline risk of BPD determines the treatment effect of dexamethasone on the combined outcome that we worry about, death and cerebral palsy. That is, that steroids are more likely to do harm if the risk of BPD is small. And he proposed using something called weighted meta-regression analysis, which I'll show you in a minute, to test that hypothesis. So we found 20 studies and more than 2,000 babies eligible for this meta-regression, a mixture of early treatment studies and later treatment studies. And this is what we found. So on the x-axis, we have the risk of BPD in the control group, so the baseline risk of BPD going from 0 up to 80%. On the y-axis, we have the effect on death or cerebral palsy. Here's 0, the line of no effect. Above the line, the control babies do worse, or steroids are causing harm. Below the line, steroids are causing benefit, reducing risk of death or BPD. And so you can see this hypothesis was confirmed that when the risk of BPD was low, the risk of steroids doing harm is quite high. But as the risk of BPD increases to the point where we get to 50 or 60%, then we start to see that steroids are actually doing more good. We repeated this exercise several years later when more trials became available, and this proved to be quite robust. The finding was quite stable. So if systematic steroids have a mixed result, would we do better if we give the steroids another way, by other routes? One theory was you could give metered aerosol steroids, inhaled budesonide, and Dirk Basler led a large study asking this question, more than 800 babies, and asked the question, did this improve death or BPD? So in the budesonide group, the primary outcome of death or BPD was lower in the budesonide group, and the p-value just hit the 0.05 mark. So there was some enthusiasm, maybe the answer had been found, but in the detail, when we look at the components of that primary outcome, we see that actually the death rate was increased in the budesonide group, compensated by a marked increase in survival without bronchopulmonary dysplasia in the placebo group. So babies with budesonide benefited in a BPD sense, but suffered in a mortality sense. Long-term follow-up showed no important differences between the two groups. But then when they looked at death at 2 years, the combined outcome, death or disability, was exactly the same. So 59% in each group, nothing going on there. But that difference in death in mortality rates now becomes statistically significant, and it favours the placebo group. In other words, budesonide is associated with a higher mortality than no treatment. And so I think our interpretation is clear. Inhaled steroids are not the solution. What about steroids mixed with surfactant and given soon after birth? And Dr. Ye from Taiwan has pioneered this way of thinking and has done a number of randomised trials. This is maybe the most important, where he randomised 265 babies, very low birth weight babies. These were quite unwell babies. They were on the ventilator. They were at least 50% oxygen in the first 4 hours of life. And he mixed budesonide with Surfactant. So Surfactant, as you know, has got quite a high volume, not terribly widely used around the world. The control group just got standard Surfactant. This was given 8 hourly until the oxygen requirement came down or the baby was extubated. Most babies had 1 or 2 doses of the surfactant. So the thought here is that by mixing the steroids with the surfactant, we get great distribution to the alveoli that needed the inflammation to be damped, and this would be more successful. And so it proved to be. There was a great reduction in that combined outcome of death or BPD from 66% in the control group to 42% in the treated group, and particularly in moderately severe BPD. So a great clinical benefit, but perhaps we're a little bit sceptical about the magnitude of that benefit. There was a corresponding lower oxygen requirement during the first weeks of life, no obvious adverse effects that were seen with systemic steroids, and a mechanism of action. The steroid reduced things like interleukins in the first week of life, so a mechanism by which the steroids dampening inflammation and then going on to reduce BPD. They did follow their babies up, but not as well as we might have liked. The follow-up rates were less than 90%. But they found no difference in neurodevelopment at that later follow-up. So we are a little bit suspicious because of the small sample size and the large effect size. Surfactant not commonly used because of its larger volume required. The restrictive inclusion criteria imposed on these babies, just the sickest babies, and the potential for bias. So some methodological concerns about this trial and incomplete follow-up. Nevertheless, we think this is a very promising therapy. So we are more than halfway through a trial. We're going to recruit more than 1,000 babies. We're up over 600 now, combining Curasurf with budesonide to see if we can reduce BPD. And I hope we'll be able to share that with you, the results of the hospital outcomes anyway, within the next 2 years. So I'm going to stop by summarising that the treatments that we can use to reduce BPD safely are caffeine in the doses and in the timing used in the CAP trial, volume targeted ventilation, postnatal steroids if we target those two babies at highest risk, and then on the horizon we've got steroids plus surfactant. I haven't had time today to mention stem cells and exosomes, which are a little bit more towards the horizon. But just like to acknowledge the contribution of someone known to perhaps some of you at this conference, my friend Amir, who led a seminars in fetal and neonatal medicine chapter on this topic. And if you're interested in reading more about BPD and the treatments available, I recommend this one to you. So thanks for your attention, and